Good afternoon, and thank you for joining us. My name is Charlie Moses. I am a coalition coordinator here with Washington Breathes. I want to welcome you to today's webinar that is part of a short series from Washington Breathes on improving cessation treatment. So next slide. Looking at our vision and our mission, Washington Breathes is a statewide coalition. We're working together to reduce the harmful impacts on our communities from commercial tobacco use, sales, and industry tactics. So we welcome you to join us, to join our coalition. If your schedule so allows for it, we would, of course, love to have you. And on the next slide, here we encourage people to get involved at whatever level works best for them and fits their availability. There are many, many ways to participate. As you can see, you can join our email list, use our online resources, come to a training, or get more involved through our work groups and policy change learning circles. More information and ways to get involved are on our website at washingtonbreathes.org as well. On the next slide, you'll see that we've developed short, informative videos for social media and other educational use. 3 of the reels focus on improving cessation treatment, and this content is available for you to reshare and post. Please do check it out. So in the Zoom chat, you'll see a little more information about this opportunity here, and you can look for us on many, many different platforms. And once again, our website will be linked in the chat. So on the next slide, here we go. We're getting into it. It's now my pleasure to turn the session over to our expert speakers from the University of Washington. Jeff Harris and Michelle Strait are also members of our cessation work group. We're so glad they can be here to share their research results and answer your questions today. During the presentation, you can put your questions into the chat or hold them until the Q&A at the end. And Jeff, I will turn it over to you.
Thank you, Charlie. First slide, please.
Yes.
So welcome, everybody. My name is Jeff Harris. I'm a professor at the University of Washington in the School of Public Health, and I'm also a researcher at the Health Promotion Research Center, which is where this work has been done. And we have been working for about 4.5 years now on helping state employees, or trying to help state employees quit tobacco. And we think that what we found is relevant to populations beyond the state employee group. So we're excited about the chance to share that with you. So I'm introducing myself now. Michelle Strait's going to introduce herself when she starts speaking in a few minutes as we move to a few slides. Next slide, please. So, the first thing we want to do is acknowledge the people that we've been working with. And I think I also want to use this as a way to set the stage for this work. We've been working with 2 groups at the Washington State Department of Health. One is the Comprehensive Cancer Program, Katie Trend and Salah Sumand there. And then also the Tobacco Control Program, Heidi Glessman and Casey Lang. And Heidi left the program for the state of Minnesota a few months ago, but she's been our principal point of contact. And then we've also been working, and so, just so you know, that those 2 programs, I mean, they do what they say they do. The Comprehensive Cancer Program has funding from CDC to do comprehensive cancer control. A lot of that is around screening for breast and cervical and colorectal cancer, but they work in other areas, and including this work on tobacco. They were our first funders for this work. And then the Tobacco Control Program works on tobacco control, and it's funded by CDC and also by significant state money. The healthcare authority is the group in state government that manages health insurance for lots and lots of people. So they manage it for state employees, they manage it for school employees, and they manage Medicaid as well, which is a huge program. And so what we've been able to do with this research is bring those two groups together and have quarterly meetings, among other things, to sort of really, I think one of the most useful things we've been able to do is to have everybody get together and be on the same page and look at the same data and learn about each other's resources and act in a more coordinated way to think about how state employees can quit tobacco use. Okay, so next slide. So, the next few slides, I'm gonna talk about tobacco control, and I know that everybody on this slide probably knows everybody on this talk knows what I'm gonna talk about, but I wanted to give you this information because I want to make sure that we're all on the same page, and there are a lot of views of tobacco control, and I want to make it clear what ours has been and why we're doing what it is we've been doing. So in 2011, 18% of Washington adults were current smokers, and that's according to the behavioral risk factor surveillance system. And now it's about 10%. I honestly can't tell you what the prevalence of tobacco use in Washington State is right now because the BRFSS data have been down on the CDC website for a couple of months since the Trump administration came into power. Those data have been down. I checked just this morning again to make sure that they weren't back up, and they're not. So we don't have the most recent data available to us. According to CDC, roughly 2/3, 62% of people who have ever smoked in the United States have quit, but that means that about a third, 38% have not. So there's certainly plenty that remains to be done. Next slide. So the keys to quitting, I think the first thing is to give people an incentive to quit. And there are two policies that are remarkable for their ability to do that. One is levying taxes on cigarettes and other forms of tobacco. And the second is having smoke-free policies, primarily for indoor public areas like the workplace and then surrounding areas outside. And the reason those are important is that research shows clearly that they stimulate quit attempts. So, we've had massive education in the United States for 3 decades now. And so as of in 2015, 68% of smokers said that they wanted to quit. And in that year alone, over half, 55% had tried. But most of them, 80 to 90%, try to quit on their own. And we know that medications or coaching can double quit success. So medications include over-the-counter medications, principally nicotine replacement therapy, but also prescription medications, principally varenicline. And coaching includes all sorts of things, including apps these days, but probably the major coaching tool is still the telephone quit lines. And we also know that if people do both these things, that quit attempts are 3 to 4 times as likely to be successful. But sadly, in 2015, only 31% of quit attempts were aided, and only 5% were aided by both. Next slide, please. So the take homes here are that quitting can succeed, and that aided quit attempts increase success, and our opportunity is to increase aided quit attempts. The last thing I want to do is talk to you a little bit about the state employees that we're working with. When I think of state employees, I think of people working in Olympia, but we're working much more broadly than that. I'm a state employee. I work at the University of Washington, as do, I think, 27,000 other people. The Public Employees Benefits Board provides insurance to about 140,000 people in the state. And that's the group that we're trying to reach. And that includes state agencies that have a lot of people in the field and a lot of people who use tobacco. So it includes people like the Department of Transportation, the people working on highways. It includes the Department of Corrections, people working in corrections facilities, including prisons across the state, and it includes the Department of Labor and Industries, and they have lots of field people doing occupational safety checks at workplaces across the state, large and small. So with that, let's move on to the next slide. And Michelle Strait, who's been with us from the beginning and has done a huge proportion of this work, is going to tell you more specifically the work that we've been doing together. Michelle?
Great. Thank you, Jeff. Yeah. Hi, everyone. Thank you for being here. My name is Michelle Strait, and I'm a research coordinator at the Health Promotion Research Center at the University of Washington. As Jeff mentioned, we've been doing this work for several years now. So I'm going to walk you through what we found and what we're doing to increase awareness and uptake of tobacco and nicotine cessation resources. So starting with our first year of work, we kicked things off with a survey with state agency employees, and then that was followed by a series of focus groups with managers and wellness coordinators. And so for the survey, we were hoping to get a baseline for employee tobacco and nicotine use, as well as thoughts around cessation promotion within their agencies. And so for this first survey, we received over 2,600 responses from 6 state agencies. The highest use rate was 16%, which was a little higher than state average at the time. And tobacco use was highest in the Department of Corrections, Department of Transportation, and Labor and Industry. Labor and Industries, those agencies that Jeff was just highlighting. 60% of respondents found that tobacco use was common at their agency, and while little over half were knowledgeable of cessation benefits offered, and 3/4 were thinking that these benefits should be actively promoted, only about 18% had actually used any of the cessation benefits. Next slide, please. So we followed up that employee survey by running 6 focus groups with managers at these same agencies. And the main takeaway was that they were supportive of cessation efforts, but not overly knowledgeable of what benefits were available. And while survey respondents found tobacco use to be common in their agencies, in the focus groups we heard the opposite, that tobacco use wasn't seen as a widespread or a common occurrence, and it was thus a low priority, especially among leadership. And a common barrier to promoting benefits was the stigma felt around tobacco use and not wanting to single out individuals with tobacco control action. And this stigma is a common theme that we ended up hearing again and again as the years went on. So then the following year, we expanded on this by holding interviews with wellness coordinators and members of wellness committees. So we had heard repeatedly that these folks were often the ones sending out or promoting wellness messages. So we wanted to go to them to learn more about how these benefits are communicated to employees. So we held 15 interviews, and we heard that most of them were volunteers in this role, and that any tasks done under the wellness coordinator umbrella were done in addition to their other responsibilities. Which sometimes made it difficult for them to spend a ton of time on promotion, depending on what exactly their job responsibilities are. And they used a variety of channels to get these wellness messages out, emails, newsletters, posting on intranets, and yet they still noticed that there was low engagement. And while we were talking with these wellness coordinators, they recommended more regular communication and leadership support in order to increase awareness and use of these cessation resources that were available via health insurance. So again, Quit for Life, Quitline, nicotine replacement therapies, things like that. Next slide, please. And so while we were in contact with these wellness coordinators, we worked with them to revise 4 cessation-related communication materials that were originally created by the Washington Department of Health, with the hopes that updating these would make it easier for the coordinators to send them out, and so that the information would be easier to find and easier to understand. And so these resources included a cessation benefit sheet. So this was an outline of what resources are available to someone based on their insurance. So Kaiser Northwest, Kaiser Permanente, Primera. And then in addition to those resources, they also listed things that adults and teens could also use regardless of insurance plan. There was a Quitline rack card. So this was a business card size takeaway that had the Quitline contact information. We also helped to edit an email template around benefits that would go out to both PEB and SEB beneficiaries. And then finally, there was a quitline table, and that outlined what was available to someone per their insurance status. So if they were unemployed or on Medicaid. And edits to these included just simple things such as making the wording more clear, or even just layout changes. And so as time went on, we continued to maintain contact with wellness coordinators. So we would provide feedback on any materials that they created, or we would share templates that they could send out easily, as well as providing other tips for engagement. And this was all in an effort to keep lines of communication open and to assist them in promoting tobacco cessation resources. It wasn't until 2022 that we began working with the Healthcare Authority, and that's when we began to communicate cessation benefits more broadly. So we presented at a wellness coordinator conference around different communication tips, and we helped to create a smart health tile, as well as sending out information around tobacco awareness days like the Great American Smokeout. And the Healthcare Authority also helped in our efforts to track cessation resource use more generally. So for example, when we asked, they were able to pull data around varenicline use. And so varenicline is a generic name for Chantix. And in 2021, Chantix was pulled due to contamination, which coincided with that drop. And so since then, generic forms of varenicline have returned to the market, and we've seen some increase in use, and we'll touch on that in a moment. But being able to see trends like this was helpful as we were going forward. Next slide, please. So all of this has led to the past year when we realized that we needed more information from employees about what barriers exist to accessing these cessation resources. So we had heard about several barriers from managers and wellness coordinators, but we hadn't delved super deep into that with any employees. So we sent out another survey asking about use and awareness of different resources, and we also held another round of focus groups, this time again with the state agency employees, primarily to hear more about these barriers as well as any beliefs and knowledge that they had around the resources. Next slide, please. And so one thing we want to know about this second survey is that we didn't get as many responses as our first one. So we only got around 310 responses compared to over 2,000 a few years ago. And we just thought this was interesting because we sent it to similar state agencies, and this second survey was even sent to a couple more. And we won't really ever know why we didn't get as many. You know, maybe folks just didn't receive it. Maybe this was just a continued burnout effect post-COVID. But regardless, we were able to get some good findings from this data. The main takeaway being that there's an overall low awareness of cessation resources. So you can see on this graph, only 52% were aware of any cessation resource, and then it decreases from there. Medications via insurance, smart health, quitline, quit for life, and then tomorrow at the bottom at 3%. Next slide, please. And not only was awareness low, but use was also low, which isn't super surprising. If someone doesn't know about a resource, they're probably not going to use it. And although almost half had tried to quit within the past year, use of quit resources was low. So for example, only 9% had used quitline or quit for life, and that was the highest use rate of the cessation resources included on this survey. Next slide, please. And then what we saw in the survey was reflected in the focus group. So there was a lack of resource awareness overall. Medications were most well known, followed by quitline and then tomorrow. And then there was also just a lack of knowledge around practical information. So how to access these resources, what was covered, how many times you could use them. And we once again heard that it's important for this information to come from multiple sources. Next slide, please. On the bright side, these resources were seen as effective when folks knew about them. So many of the focus group attendees had used cessation resources, and there were mixed results in terms of relapse. Some had successfully quit using tobacco and nicotine, while others had more peaks and valleys. And of those who had used medications, we did hear a lot about their experiences with side effects. Some shared that they weren't overly aware prior to starting the medications that there'd be side effects or how intense they would be. And this just further highlighted that kind of confusion around these resources that seem to be there. Next slide, please. So from the focus groups, we heard of several barriers to using these cessation resources. So again, there's that lack of information. So maybe websites aren't easy to find or specific information isn't listed, so they don't use it. There's a perception that these can take up a lot of time. So several mentioned specifically for Quitline that they just couldn't commit to various calls throughout the week in addition to their other responsibilities, particularly when they already have questions about what the calls will be like or how long they'll last. And then there's also the barrier of accessing the messaging. So if these resources are only advertised via email or on the intranet, then people not at a computer, such as those working outside, miss those messages. And again, this is just important to remember, just like Jeff said at the beginning, because although some folks might imagine a state employee is just someone at a computer in Olympia, it really runs the gamut of various different occupations. Next slide, please. And then finally, one of the largest barriers reflected in both the survey and the focus groups throughout the years was stigma. So most recently on this survey, over half of respondents felt judged for their tobacco use, and a fifth wanted their worksite to be more supportive of their quitting efforts. And there was also a fear of penalization mentioned during the focus groups, with some expressing concern that because they lied about their tobacco use to avoid paying a higher premium, that they might get flagged if they then tried to use their benefits to access any of these cessation resources, either for themselves or for one of their loved ones. Next slide. So all of these findings led to our most recent work. So our current goal is to counter the barriers that we've been hearing about. So putting out messaging clearly saying how to access these resources and what you can expect when you do. Getting this information out often with a variety of ways, and being sure to touch on topics that we've heard again and again are important to folks. Specifically in this past year, we've worked with the Healthcare Authority to send out quarterly messages, and we've also helped to create a few smart health tiles. So these messages address topics that we heard in the survey and focus groups are important to employees, such as just basic information about the resources and how to access them, youth tobacco use, vaping, and easy to access options such as app or phone-based resources. As we're making these messages, we're working to keep them brief and clear and just really highlighting the resources and also showing that they're not just for beneficiaries, but also for any dependents as well. Next slide, please. And we're also, of course, continuing to look into the data around tobacco and around cessation resource use. So for example, this slide shows a 20% uptick in both cessation medication prescriptions filled and the number of people trying to quit with medication assistance in 2024 compared to 2022. So we found this uptick promising, particularly just considering all the work that the Healthcare Authority, DOA, Department of Health, and our own team have been doing in the past few years. Next slide, please. And so going forward, we're hoping to increase communication around these resources. The feedback from the messages that we've been putting out most recently has been slow to come in, but it has been really positive. So we'll continue to highlight in different ways the topics that we've heard are important, again, such as youth tobacco use and vaping, and we'll work on expanding the ways folks are actually getting these messages. Any communications that go out in the future by us or our partners will continue to advocate for them highlighting practical information, as well as using supportive and non-stigmatizing language, just to really focus on combating that stigma. And then, of course, we'll continue our partnerships with the Department of Health, Healthcare Authority, and Washington Breathes as they strive to expand this work. Next slide, please. So I just want to say thank you all for taking the time today. Jeff and I are happy to answer any questions you may have. I saw a question
Oh.
in the chat around social media graphics. We don't currently have any plans for that, but I think that's definitely something we could work with our partners on. Jeff, I don't know if you wanted to add anything.
No.
I have a couple of questions. Sorry, my microphone wasn't working before. The first one is, are you looking at any options for contingency management interventions, such as offering cash vouchers or gift cards for employees? I'm looking at the idea of these brief interventions and that there's shown a lot of promising outcomes from offering some type of reward associated with the quit attempt and sustained quit.
Brandon, I think we're not. I think it's very hard in the public sector to do that. We haven't even been able to offer even small rewards for completing surveys. I think there is there's a reduction of the negative penalty. When we talked about I think it's about $300 a year that people pay an additional health insurance premium if they say that they or their family members are current smokers or current tobacco users. And so, that's a pretty big incentive. And so that there is that if someone is able, and you actually don't have to be a current user. I mean, a current non-user. You can also be a current user who says that you're engaged in a quit attempt. And so, again, I think that is there, but I think I don't want to equate the two. I think it's what you're raising is a really good idea, but I think it's pretty hard in the public sector to put into place incentives like that. I don't know,
Yeah.
Michelle, if you had anything else you want to offer, but.
No, those were kind of my thoughts too. Thanks, Jeff.
Yeah. I think the premiums would be a good alternative for that. So exploring that. My other question is, when you're looking at tailoring your resources, are you looking at gain versus loss framing messaging? I can send you some links around some of the scale trials that have happened around brief tobacco interventions with shared decision making and lung cancer screening, but gain frame messaging is showing more positive outcomes in these brief interventions. So utilizing that with your educational resources.
Yeah, it's a good point. And I think we are moving in that direction. Yeah, yeah, yeah. As well as, I think one of the other things we really tried to pay much more attention to is just trying to convey support. No matter how hard, for Michelle and me, this isn't the only work we've been doing. We also did some focus group work. We spent a year. We do some other work in the workplace, particularly small, low-wage workplaces, and we had the opportunity to look at our messaging and our materials over the year during focus groups across the country, working with state tobacco control programs and then employees in small companies and managers in small companies. And this issue of stigma, particularly for the smokers, for the people who use tobacco, is just something that came up again and again and again and again, and that they really felt everybody was out to get them, or that everybody thought badly about them, or that everybody thought they were stupid, and that that you can't overdo. Their message to us was that you can't overdo conveying support on the part of the workplace, that we're not here to get you. And so we've even had discussions about whether the penalty for tobacco use and the insurance makes sense. Those discussions haven't gone very far. I think there's a lot of, I think partially the response we get is that that's designed to offset costs for people who don't use tobacco, but it's something we'll continue to discuss for that reason. Yeah.
Okay.
But good questions. Thank you.
Yeah, my last one is more a comment than a question of anything, but looking in the future around like shared decision making support, and I don't know how that would look in this setting with medication use, I think would be helpful as far as addressing those barriers around perceived side effects or adverse effects from medication use. So, we talk to patients often at Fred Hutch who maybe even starting at a lower dose nicotine patch helps overcome that hesitancy to begin with. And for a lot of people, they've never explored those options, even with a healthcare provider. they might just get prescribed step 1 patches and go from there. So I think that would be really useful in some of your educational materials.
Do you want to comment, Michelle, or I don't mean to?
No, you can go
augment?
ahead. I'm taking notes.
Well, I think one of the things we've tried to do in this is talk with the health plans, because these the benefits are we call them benefits, but we're talking about insurance benefits, insurance resources, insurance funded resources, including medications and various and sundry coaching modalities. And we try to talk with them as well as with the folks at the quit line about what we're finding. There's no way that that the state agencies are going to get into shared decision making on an individual basis. That's just not what they're going to do. It's not what they have the resources to do. As Michelle mentioned, all the people that we've worked with are volunteers. They do this. It's sort of other duties as assigned to do this work, and we found it, frankly, harder and harder to connect with those folks as we've been coming out of the pandemic. We don't really know what that's about. We've actually tried to explore it, and we haven't really gotten good answers as to what it's about. But I think that's good advice in terms of giving advice to the to Regions, and we've talked to Regions Primera and Kaiser Permanente quite a bit about what they're doing. So yeah, I think that's a good idea. But the agencies themselves aren't going to do it. I think, and I tried to do the arithmetic on the slide that Michelle put up in my head, that that showed the quit attempts. And if we assume that there are 140,000 people that are covered by the Public Employees Benefits Board, and if we assume 10% of them are smokers, which is a reasonable assumption, I mean, there's no reason to believe that then we basically, about 10% of smoker tobacco users are currently using these medications, which is not terrible, but it's apparently been quite a bit lower for quit line use. It's been hard to get real numbers, but it's apparently been quite a bit lower. So if you followed my arithmetic. Other questions, comments?
I have a question or comment, just kind of around the fear of being penalized, as well as the stigma and shame. Is there truth behind being penalized? Was this a rumor that kind of spread like wildfire throughout various places?
Yeah, there's no truth behind it at all. But I think it's very hard to convince people of things like that. When we work with the healthcare authority, we've suggested that they might want to go out to individual tobacco users with the information to target it more. And the answer to that is always no way. Because, we are not going to target people individually. That information is there, but it's completely firewalled. And so there is not that level of individual effort information, and we're not going to use that and it's not available to the health plans. Have what they have via their clinical systems, but they don't have it from anything that they get from the healthcare authority. So I don't think we try to go out with any messaging about that, because we don't know how prevalent it is, that concern, but we certainly heard it several times. But there is absolutely no truth to it. I'm in some ways it's been a little frustrating to us, because we would love to be able to to reach out more directly, since we've had a little more trouble recently going through these wellness coordinators, and the healthcare authority is just like, well, this is not a conversation we're having. We are not, we don't want people to have any doubts about how confidential their information is. So.
And the prevalence of stigma when you've been doing this research, is that something that you've been able to measure, find metrics on?
Michelle, do you want to try to take a shot at that? Yeah.
Can't say that we have any like specific questions other than I can't remember the exact wording right now, but you know, like, do you feel judged around your tobacco use and things like that, and then exploring it further in focus groups. Yeah, I wish I could remember the exact wording that we put on the surveys right now, but we really tried to get more of their actual words in the focus groups and hear more about what that felt like and why they felt like that. And then that's why some of the main goals was just rewording that messaging to be more supportive and less kind of, you know, punitive or with that kind of bend that traditionally is on tobacco cessation, you know, pamphlets.
But yeah, I think that's right. I don't know an exact number. I know in the focus groups, once somebody brings it up, everybody starts nodding. Every tobacco user starts nodding. I mean, it's a very, very prevalent, and former users talk about it as well. We've had quite a few former users and just how targeted they feel and feel and felt as tobacco users. So.
Yeah, I wanted to highlight Margaret's comment in the chat. If anybody here as an attendee has uh, experienced various blocks in cessation with their own communities or challenges that you've faced, it's a good time to have a quick discussion about it.
Absolutely, and not just, I mean, we have quite a group of people here, so we could have some exchange as well. It's not just for Michelle and me, but it's great to have Brandon here, but it's also great to have so many people who are working in various settings across the state.
Well, people are thinking about those questions. I will also share a question. There was someone here earlier that sent me a private message because they knew they had to leave early, but they're interested in what you and others in the group would say are actions that are needed to make cessation medications, NRTs more accessible to people. I mean, you can also say how much of the problem is that, and then what could be done to make them more available to people, because the evidence shows that really makes quit attempts more successful.
Well, the good news for state employees is that nicotine replacement therapy is a covered, even though it's over the counter, these are over the counter medications, that it is a covered benefit for, I believe, for all three of the major plans. And so, Regions and Primera and Casa Permanente. So that's the main thing, but that's certainly not true more broadly in the commercial insurance world. There's a tradition of not covering over-the-counter medications, and so I think the first thing to do is that if you're an employer or someone who has any control over this, is to make sure that you're actually covering this over-the-counter medication. I'm not saying you should cover all over-the-counter medications, but that's nicotine replacement therapy is still, a very, very popular medication. I was surprised that it was, at least in the prescription data from the state employees, that it was actually before the whole problem with Varenicline being withdrawn, Chantix being withdrawn from the market. Varenicline, there were more Varenicline prescriptions than there were nicotine replacement therapy, but in the broad world, nicotine replacement therapy use greatly outnumbers or Varenicline or bupropion use. So just that's the first step to make it easy. I'd love anybody else's ideas on how we can make it more available to people, but just to remove that barrier. Brandon, do you have any thoughts on that?
Yes. I mean, my moonshot goal would be what we offer through Fred Hutch Cancer Center is we offer no cost nicotine replacement therapy for our patients who are either receiving active cancer treatment or within one of our high risk prevention programs. Unfortunately, we don't get any like state support through that. That was completely through philanthropy as our coverage for that. But I think that is removing that barrier to so many of the patients I work with. And actually, probably what I'd attribute a lot of the lack of retention in the quit lines is people I work with are like, it was great, it was helpful, but I only got 2 weeks of nicotine replacement therapy, and that wasn't enough to support my quit attempt. So, yeah, that would be my hope.
Well, yeah, I mean,
Maybe
you're
someday.
making a really good point. I mean, I think if you, from a public policy standpoint, making nicotine replacement, making 12 weeks of nicotine replacement therapy free for all users of the quit line, whether they're funded by commercial insurance or not, would be a really worthy goal. There's no question about that.
Yeah, I think a good example of that actually would be like MD Anderson does a tobacco treatment program, and I believe their like state tobacco quit line goes through their program as well.
Yeah. But it is covered for 7 PED. Nicotine replacement therapy is for state employees and public employees. And I think one of the big messages from our work is that most people don't know that. And so the first step also is to get that out and make sure that they not only know it, but that their beneficiaries know it as well, their spouses and their children who, their adolescent and young adult children who are covered beneficiaries are aware of the resources that are available to them. Yeah. And that's what we've been trying to do. I think the healthcare authority, over the course of the 5 years that we've been working with them, the level of effort that they've been making around getting that information out and the channels that they're using to do that has just blossomed. So it's been really gratifying to work with them and to see the energy that they're putting into it and the conversations that they're having with the health plans to make sure the health plans are getting that information out. It's been a really positive aspect of the work that we've done with them. So again, Michelle, if you have any comments.
No, my only comment was going to be just, yeah, it doesn't matter if they cover it if no one knows it. So just expanding that communication around it, making it really easy for folks to get that information. And even just having someone where they can ask questions if they have any, just again, increasing access to all that information.
Yeah, Margaret, do you want to comment on your factoid from the chat?
Sure. I just shared that, and that's on our website. One of our priority issues is improving cessation treatment. So if you look under our priority issues, you'll find more factoids like that. One comment is, I wish I had more current data than 2021 on that, but I think that is showing the funding gap in our state. And I appreciated, Jeff, that you mentioned that, or Brandon mentioned, I think you both were saying similar things, that, people really need 12 weeks of NRT to really, even then they may need another quit attempt, right? But 12 weeks is what they are going to need to taper off. And if what's free through the quit line is only 2 weeks, it's just, that's really hard. So I think that data on that we're certainly not investing as much as CDC, recommendations in the past, and I think it shows. I think there have been some amazing, great new things about the quit line. There are now more tailored services for specific communities. For
Right.
Native Americans, I think there's another one coming for LGBTQ community, and I think that's super important too, because we have heard feedback through Washington Breeze circles that you know, when people call the quit line, it's a hard thing, you know, to reach out, and they want to reach someone that they feel like is understanding them, maybe communicating in their language. It's important to just get those services going. Yeah, and we have someone in chat whose family member just quit. That's fantastic. Yeah. But neither, yeah. Sounds like it was a hard quit effort.
Yeah, I'd say, Manette, that, you know, the experience of the people we talk to in these focus groups is aligns with your experience, or, you know, the experience of your family member, unfortunately. And that's part of what we've been trying to work on.
Is there a messaging channel that you found to be the most effective overall?
Well, I mean, I think the messaging channel that we're ending up working with just it changed over time. I mean, when we first started this, there was a lot of attention given to the, you know, to the worksite wellness program at the state of Washington, and the wellness coordinators were communicating quite often, and we had a sense that all the messages we were sending were going out, and, you know, as we said, we got over 2,000 people to participate in our first survey. And that has just dried up. And I don't know if it's, you know, there's no question that that program became less of a priority for the Inslee administration. You know, there were a lot of other things going on. There was this thing called COVID. And coming back from COVID, there just was a lot going on. So I'm not being critical here, but I think, you know, smart health has become one of our major, you know, which is something that all people who are covered through the Public Employees Benefits Board have access to and are encouraged to use, is probably the channel that we've been focusing on more than any other. And then, as I said, we've also been going directly to the health plans to get this information to them so that they can use it to go directly to their beneficiaries. You know, all of them, not targeted. And then we worked. You know, we've also worked directly with the University of Washington. I mean, we do have 27,000 employees, and we've been able to get messaging out directly from them. For some reason, I get very, very little communication from the healthcare authority as an employee of the state of Washington. I mean, I get the stuff about benefits fairs in the fall, but I don't get much else. And same for Michelle. And so we've been able to do direct messaging through UW to our, you know, pretty large employee base. So I think email is still a tool. But I don't know, we've tried to do some other things like the old, you know, put it on the back of bathroom stalls. We have a sticker with the number that we made lots of copies of, put it on the back of bathroom stalls. I don't know how relevant that is right now. I mean, it's because a lot of people are still working from home. So, Michelle, do you want to add to that?
Yeah, just trying to hit those multiple messages. So maybe at like wellness fairs, folks can hand out that sticker, or yeah, see the poster boards up. And then I would agree with the smart health that, you know, it's not quite an email, so it might be slightly less easy to ignore or just delete from your inbox. And then folks do still get points. So getting them to engage in those activities. But if folks have other ideas for engagement, we are happy to hear about them and kind of consider those going forward.
I mean, I'm not sure if everybody knows, but if you participate in Smart Health, if you get points, you accumulate these points, and if you accumulate 2,000 of them during a year for healthy behaviors, then you get I think it's $125 discount on your health insurance the following year. And so we're about to roll out one that Michelle has designed that gives people I think 200 points or something like that if they actually contact the quit line.
Yeah.
So they get 50 points just for reading about cessation, and then if they contact the quit line, they get another 200 points, which is some 10% of the way towards that $125 incentive.
Great. Well, thank you both so much. Any other thoughts, questions before we wrap it up for the afternoon?
I was going to
Yeah,
ask
Paul, did you
Paul.
want to, I mean, I saw Michelle's comment but go ahead, Brandon.
I don't know, I was going to ask Paul to share any experiences as well. I saw you were on the
Yeah.
call.
Thank you, Brandon. Thank you, Jeff and Michelle. And yeah, so some of the things that I've noticed in working with veterans the last couple of years, and they actually do walk up to me and say, look, I don't want to waste your time here, but is this going to go in my VA jacket, right? In a file somewhere, you know? So we have a conversation about that. And then the provision of NRT, it really helps them if it's right in front of them. And I'm sure you're experiencing this too, Brandon. And if you have it right there, right, they don't have to wait for it. They don't have to go through any red tape, filling out forms, applications. And that is an incentive in itself, just to have it immediately available. And then the other thing is obviously we're eliminating the cost of that NRT. And that's all I have right now.
You know, I work with a program in Alaska with Alaska Natives at South Central Foundation, which is a big healthcare provider in in the Anchorage area. And one of the things that they do that I think is strongly evidence-based that is really helpful along the lines of what we just talked about and what in Brandon's work is that if a tobacco user is identified by primary care, they're very quickly uh, uh, moved to trained tobacco specialists so that the primary care provider doesn't bear a lot of that responsibility because primary care providers have a lot of other things on their mind, and they are connected with a devoted program with medications available, with also with a specialist like Brandon, who can talk to them and again facilitate access to medications and such. So I think that's another best practice. I don't know how relevant it is to people on this call, but it's a good thing to do.
That's what I was thinking a little bit too about your messaging. If there's an opportunity around lung cancer screening eligibility, whether that's from a harm reduction standpoint for somebody who's currently using tobacco, but there's also the second order effect when somebody enrolls in lung cancer screening. You have this teachable moment opportunity that really enhances quit rate success. So that might be another opportunity to think about, as far as you might not hear from people going in that they're doing it for
Right.
tobacco treatment, but when they show up for that CT scan, you might find really effective quit rates just from that.
Yeah, I think that's a great opportunity. I think the VA has done quite a bit of work on that actually with veterans. And still, I think in the general population, the prevalence of screening among people who are eligible is about 20%, something like that. So is it 5? Oh, okay. Even worse than I thought. Yeah. Can't tell you how many times I've had that conversation with my sister. Okay.
All right. Well, Jeff and Michelle, thank you both so much for taking the time today and presenting. And it's such a good turnout of people, and I appreciate everybody for taking the time out of their schedule this afternoon. Thank you. I have 2 shameless plugs for Washington Breeds. One is that if you would like to participate in our Improving Cessation Treatment Work Group, we're gathering tomorrow at 2 o'clock online. That is a virtual work group. And then the second shameless plug is that we have another cessation webinar scheduled for April 21st with Dr. Crystal Shen. We'll talk about youth nicotine addiction, and this session is designed for school professionals and youth-focused prevention and public health staff. So if you have anyone in your life who may be interested in that, please do feel free to pass along this information to them. But thank you all again so much, and a big giant thank you to Jeff and Michelle.